When nerve impulses travel along a healthy muscle fiber, they follow a predictable sequence. But in motility disorders, these signals spark and fail. Identifying these conditions requires looking past clinical complaints like chest pain and focusing on these mechanical breakdowns. To differentiate these disorders, clinicians rely on a two-variable physiological matrix that maps the relationship between the esophageal body and its sphincters. The first variable is the presence or absence of a coordinated sequential peristaltic wave moving down the esophageal body. The second is the resting tone and relaxation capacity of the lower esophageal sphincter, which must relax and open as that wave approaches. Shifting these two values allows us to categorize the specific mechanisms behind achalasia, diffuse esophageal spasm, and scleroderma. Because symptoms like dysphagia often overlap between these conditions, this mechanical map provides the data necessary to distinguish one pathology from another. Achalasia begins with the progressive degeneration of nitric oxide and vasoactive intestinal peptide-producing neurons within the esophageal myenteric plexus. This neurological loss leads to the first mechanical deficit, a total failure of peristaltic coordination, appearing on manometry as a flat, non-reactive line. Expanding to the sphincter level reveals the second deficit. The sphincter fails to relax, maintaining a permanently elevated high-pressure band. This pressure differential creates a specific radiographic signature. This text notes that on a barium swallow, achalasia classically appears as a dilated esophagus with a distal taper. This persistent clamping forces structural changes over time, as the esophagus dilates to accommodate food that cannot pass through the hypertensive sphincter. Treatment focuses on manually overcoming this mechanical failure through pneumatic dilation, botulinum toxin injection, or a surgical myotomy. This categorizes achalasia as a dual deficit, the complete absence of peristalsis, combined with a hypertonic, non-relaxing sphincter. A different pathology occurs when the inhibitory innervation is impaired, but the smooth muscle architecture remains intact and reactive. In this environment, the esophagus undergoes an uncoordinated muscular storm, where multiple segments contract simultaneously without moving contents forward. This manometric tracing shows the results: premature, simultaneous, non-peristaltic contractions appearing as massive pressure spikes throughout the esophageal body. Focusing on the sphincter reveals the difference from achalasia. Despite the erratic pressure above, the sphincter itself demonstrates a normal, timed relaxation. These uncoordinated contractions cause severe, crushing retrosternal chest pain that can be mistaken for a myocardial infarction. Because the muscle is hyperreactive, management requires smooth muscle relaxants, such as calcium channel blockers or nitrates. This shared physiology means that both cardiac and esophageal smooth muscle relax in response to nitric oxide. This can lead to clinical mimicry, where symptom relief alone does not confirm the source of the pain. In the condition known as systemic sclerosis, the esophageal architecture is altered as stiff collagenous fibrosis replaces the smooth muscle. As a result, manometry shows completely absent peristalsis in the lower two-thirds of the esophagus, where the muscle has been replaced. This fibrosis also destroys the mechanical integrity of the sphincter, leading to a collapsed, near-zero resting pressure. This leaves the esophagus open to severe gastroesophageal reflux, requiring aggressive proton pump inhibitor therapy to manage the complications. We organize these pathologies into a grid, comparing peristalsis against sphincter tone. Absent peristalsis with a high-tone sphincter identifies achalasia. Chaotic contractions with a normal sphincter identifies diffuse esophageal spasm. Absent peristalsis with a collapsed sphincter identifies scleroderma. Using these specific manometric intersections provides a framework to differentiate these pathologies when symptoms like chest pain or dysphagia overlap. Consider a patient with crushing retrosternal chest pain that radiates to the back, specifically triggered by cold liquids. The cardiac workup is negative, with a normal ECG, negative troponins, and an unremarkable exercise stress test. The patient is administered sublingual nitroglycerin, resulting in the complete resolution of the chest pain. We must now identify the test required to confirm the diagnosis from these clinical options. We rule out coronary angiography, Although nitroglycerin relieved the pain, the negative stress test has already ruled out anatomical coronary artery disease. 24-hour pH monitoring is the gold standard for diagnosing acid reflux, but reflux does not classically cause crushing pain specifically precipitated by cold liquids. Upper endoscopy rules out structural blockages, but because motility disorders are functional rather than structural, the mucosal lining will appear normal. A barium swallow may suggest a corkscrew pattern, but it does not provide the precise pressure data needed for a definitive confirmation. High-resolution manometry is the required study. It captures the specific simultaneous contractions that confirm a diagnosis of diffuse esophageal spasm. Mapping the pressure relationship between the esophageal body and the sphincter allows clinicians to distinguish between gastrointestinal motility issues and cardiac mimics.